My name is Matthew Fold from Siemens Healthineers. I am the product manager for photon-counting technology. We've been talking about it at Siemens for almost 20 years in terms of R&D. I was one of the scientists at one of our early prototypes, and so to actually see it as a real device with clinical users all around the world is pretty amazing. So I will give a brief introduction about the technology, and then we have real-world clinical users, Ricardo Bude from Erasmus Medical Center, who will join me in showing you the amazing pictures that you can see with photon counting. So I always talk about CT. I have to start somewhere, and you know, when we think about CT, we think about these three main things. It's about detailed resolution. So in this space, it's coronary plaque, it's the walls of the valves, it's, you know, being able to see edges of calcification with confidence. And so when you do that in conventional scanning, it's a trade-off between radiation dose and spatial resolution information. It's always a balance and a compromise. Speed is critically important, especially in cardiovascular imaging. If you can't stop the motion of whatever you're looking at, it doesn't matter what spatial resolution you have, it's irrelevant because it'll be blurry. And if you have a scanner that was developed in, say, maybe the last decade, you have probably moved beyond simple structure and moved into composition and function, what people call a lot of different things, I guess what the new SCCT lexicon calls multi-energy imaging, spectral dual energy. The challenge is that no scanner in the world could do high resolution at low dose, the speed to stop all motion, spectral information, all at the same time. And that's no longer true. The Neotome Alpha with photon counting technology built into a dual source CT can do all of these things simultaneously, and it really will have a great effect on cardiac CT. It's these four main technical principles, and if you were in the room munching on your lunch beforehand, you may have glimmered some of them from the video that I was looping, but contrast-rich images, better iodine signal because of how we weight the X-rays without diving in too deep into the physics. The smaller pixels, without the need for light-reflecting septa, we can make much smaller elements on the detector, allowing you to go to much higher spatial resolutions. Spatial resolutions that we would have only achieved in the past at very high doses for things like the inner ear or the wrist, but we can now do them in the thorax, for the heart, for the lungs. Spectral information built into every scan because we measure the energy of every X-ray that hits. It's not an average signal, it's not a scintillator, it's not a multi-layer, it's every individual X-ray that hits, we know its energy and can use that for many advantages. And then because we can measure its energy, you can differentiate very easily between what is a real signal and what's noise. An X-ray needs a certain amount of energy to get through the body. So if it's at a certain level, it can't be there, it must be noise. And we can simply throw that completely away with this technology. A conventional energy integrating, as I mentioned, this is any scanner that you have if you don't have a Neotome Alpha, is this. It's a ceramic material. When you hit it with an X-ray, you create light. And in order to control the light, we have to put these walls in between them, light reflecting septa. If you don't do that, you have no spatial resolution. So you want to see the edges of the coronary, it's blurry. To get more resolution, you put in more light reflective septa. The challenge is that if an X-ray hits one of those, you get no signal. And so high resolution comes at an extreme dose penalty. All of the light is averaged together. We think of light as fast, but actually it's not fast enough to measure. We average the signal of about 30,000 X-rays together in a single projection, 1,000 projections as you go around. So no spectral information from the light directly. Photon counting is different. It's a crystal semiconductor instead of a ceramic scintillator. When an X-ray hits the material, it creates electrical charge, electron hole pairs. We can measure directly. The amount of charge that is deposited is proportional to the X-ray energy. So we have the information of each X-ray impact. If you can measure fast enough, 8 nanoseconds, you can measure every individual X-ray, and that's what we've done. faster electronics as well as smaller detector pixels. And so we have the ability to do those technological advancements that I mentioned. Smaller pixels giving us higher resolution by default, and ultra high resolution without a dose penalty. No electronic noise because we can simply threshold away what would be artificial signal. Spectral imaging in every scan. Not possible before in things like the coronaries. You could do it in the myocardium, get a sort of blurry picture of iodine intensity. Now you have the temporal resolution of dual source CT with spectral information, while you have better contrast information, because we handle the physics of low energy photons better, make them brighter. They're treated equally across the board. Built into dual source, so it's photon counting plus dual source. If you're familiar with the Symposium force, and I'm sure almost all of you are, it's the same temporal resolution, same volumetric speed, but with photon counting technology. That's 66 millisecond temporal resolution to give you high quality coronaries, any heart rate, any time, any patient. Volumetric coverage for single heartbeat imaging, for triple rule outs for the vascular portion of your TAVI exams. You can do any patient with dual source technology. Photon counting on the Natum alpha takes that even further. It unveils impressive new details, high resolution by default, and ultra high spatial resolution. You can compare it to the force. The force has been the gold standard of CT in the industry for years, and you can compare these coronary images, the delineation, the detail on the Natum alpha is just better at the same radiation dose. We get better quality. You can use that for heavy calcification. You can use it for stent imaging. You see the ringing inside the stent. It's a lack of spatial resolution. On photon counting, you can see inside the stent. Evaluate for plaque buildup, for restenosis. No more do you have to send someone to the cath lab for that diagnostic exam. You can do it on a CT scan with confidence. We can do ultra high resolution, 0.11 millimeter spatial resolution, 0.2 millimeter slice thickness in the heart. Eliminate calcium blooming, have high confidence. You can see the details here. Ricardo will show some great examples. It's part of our new software that was FDA cleared 3 days ago. So we're very excited to see it here in the United States. There have been great scientific publications proving the value, improving the identification of plaques prone to rupture, because you can do high resolution. The ability to see those small calcifications rather than the blurry soft plaque impression that you get there is dramatically different. We can see more and see it better. We can also explore more patients because we can use spectral information at the same time with high resolution. So we can eliminate calcium blooming as we've done here. So we can create a virtual non-calcium image. Keep the iodine signal, allow you to do a full CTA, but see the full lumen without the effects of calcium blooming. We can also use the better iodine signal to reduce contrast needs. It's a big challenge that we've all faced in the last months. By having better use of the signal, by having low monoenergetic in conjunction with that, we can really boost signal and use dramatically low levels of contrast. The delta here of 145 versus 55 mLs in this vascular scan. I argue the scan on the right is better. And get all of this without compromises, without sacrificing speed or spatial resolution, so that we can look at new endeavors, look at iodine distribution in the myocardium, look for scar, not sending somebody to an MR, sending them to a CT to try to drive these types of things forward. And so really, it's going to push the boundaries. You will see some really great images from the clinicians. It's my pleasure to introduce Dr. Ricardo Boudet from Erasmus Medical Center, who will share his experience. And we will hopefully have a few minutes for questions. We will, of course, stick around if you have questions and time runs out.
Okay, thank you so much, Matt, for the introduction, and thanks to Siemens for asking me to present some of our initial experiences with the photon counting CT and the ultra-high resolution acquisition mode in particular. These are my disclosures. So, as all of you know, of course, CTA is excellent for rule out of coronary artery disease, but there are still some things with coronary CTA that are on our wish list. Of course, we want to reduce calcium blooming to improve the positive predictive value of CCTA. We want to improve coronary in-stent imaging. We want to visualize smaller arteries. We want to do more detailed plaque imaging, and we want to have more detailed imaging of prosthetic heart valves and endografts. And I think photon-counting CT, especially with ultra-high resolution imaging, can help in all of these areas, and that will improve diagnostic accuracy of CCTA, making more patients eligible for it, and improve also vessel segmentation. So on the photon-counting CT, we have two acquisition modes available at the moment. So we have the normal, which is also already a high-resolution imaging mode using 0.4 slice thickness, which can be used, of course, with prospective and retrospective EKG gating as well as flash acquisition. And then we also have the ability to do ultra-high resolution imaging, where we don't have an 0.4 but an 0.2 slice thickness at 120 slices that we can use. And that is what we call the ultra-high resolution acquisition mode, all using dual source imaging with a high temporal resolution of 66 milliseconds due to the rotation time of 0.25 seconds. This is our photon counting scanner. We had it installed a little over a year ago, and up to now we have performed over 3,000 scans on the scanner. And what we immediately noticed when we started doing coronary imaging with photon counting CT is that we could go up to much higher kernels. So this is an image scanned and reconstructed at 0.4 millimeter thickness, and the upper image is with a BV40 kernel, and if we reconstruct with BV48, we immediately see that we get a better depiction of the plaque, sharper edges, less blooming artifact, easier to assess the plaque, and probably also better for quantification of plaques. So we started to do that on a regular basis. So this is another example, a patient that has a plaque in a small OM branch located over here. And when we reconstruct that in plane with the vessel axis, we can immediately see that we can have a good visualization of the plaque. There's outward remodeling, there's good visualization of the vessel lumen. And we also can see that this is not only non-calcified plaque, but there's a small microcalcification in the plaque as well. Highly detailed imaging that we have not been able to do before. Then looking at stent imaging, also this is an 0.4 millimeter acquisition. Patient received a stent in the LAD for a previous non-STEMI. CT was done for a follow-up of stent patency. And this is done at a DLP of 129. So this is a relatively low dose scan. And notice that it's the lumen of the stent can be clearly assessed, where we can confirm vessel patency, stent patency. But also notice that the original plaque in the coronary artery, which has now been pushed out into the lumen of the LAD by the stent, can be perfectly assessed with photon-counting CT. Notice the level of detail that we have both in the stent as well as of the plaque and the surrounding epicardial fat. And remember, this is still with 0.4, so we're not yet at the ultra-high resolution imaging with this scan yet. We can also do it in a high-pitch acquisition. This is a patient that was scanned prior to pulmonary vein ablation using a flash scan, a protocol not specifically tailored for coronary assessment. Heart rate was low, 55 beats per minute, and we see that we also can get good image quality of the coronary arteries, even at this low dose of a DLP of 62, which, depending on the conversion factor, is either just below a millisievert or just above a millisievert. So very low dose imaging with high pitch acquisitions. This is a recent publication from the group by Zurich, in Zurich, that looked at specific reconstructions using ultra-high resolution, and they found that if we compare BV40 filters at 0.6 millimeters with BV56 at 0.2, we get a 16% reduction in blooming artifact. And that's also what we found, comparing BV48 with BV56, 0.6 versus 0.2, notice the improvement in image quality. This is a scan that we did in a patient after heart transplantation. For European standards, this is a big patient, BMI of 33, and we scanned the patient on the force 2 years previously. Similar heart rate, and also notice that the DLP is in the same range. Notice that the alpha images on the alpha have a much lower noise, so it's improved by a factor of 2.5 compared to the images on the force. And even if we go to a BV49 filter on the force, and even when we go down to 0.2, we get an even better image quality on the alpha. So this is another patient, post-heart lung transplant, relatively low dose, DOP of 155, scanned prospectively with a prospective EKG triggering, and at a high heart rate, 85 beats per minute, so not ideal for coronary imaging. And when we reconstruct the images at 0.6 millimeters with a BV40 filter, these are the images we get, already high resolution. But then if we go up to 0.2 reconstruction with a BV72 filter, so a very high kernel, we get an excellent image quality. Look at the level of detail we get of the plaques in the LAD, showing that this is not only calcification, but there is soft plaque as well. I mean, this is a level of detail that we've never seen before. At least I have never seen before when doing coronary CTA. And I think these are actually amazing images. It's not only the coronaries, also the other structures in the heart. For instance, the chordae tendineae here of the mitral valve, beautifully visualized, and as well here the tricuspid valve. Notice that we can even see the leaflets of the tricuspid valve in this CT scan. But we also use it in patients that are prior to TAVI planning. We use a 3-step acquisition, a non-contrast enhanced scan for calcium scoring, a CTA of the, for annular sizing, and then a flash scan to assess the entire vascular anatomy in the patient. And this is not an ideal patient because the calcium score is sky high, it's almost 1300. The heart rate is all over the place, varying from 133 to 62, highly irregular, so not an ideal candidate for scanning. But these are the images we get. Look at the level of detail we get from the aortic valve leaflets. Notice the small calcification here, how well it's depicted, and the tissue of the valve that we can be seen across it. And that at the heart rate that you've just seen, very high, very irregular. But also the coronary arteries. This was scanned at 0.2, then reconstructed at 0.6 with a BV40 kernel. And this is the LAD, and it's difficult to assess whether the lumen is patent here. But if we go down to 0.2 at BV56, notice how the calcification blooming artifacts have been severely reduced. And now we can assess the lumen. And this might open the way for pre-TAVI scanning, where we can actually visualize and assess the coronary arteries in enough detail to prevent the invasive angio, which is standardly performed prior to these procedures in our hospital. As a bonus, when we do the flash acquisition to assess the access route, this patient had 2 prosthetic hips. Notice the artifacts originating from the hip prosthesis. Using the IMAR, so the metal artifact reduction, we can get rid of almost all of these artifacts and be able to assess the femoral vessels in good quality. And then there are, of course, patients that have already received the valve. This is a patient after a valve-in-valve TAVI, patient with a BMI of 27, 94 kilograms, 70-year-old, and we scanned the patient to assess valve function. This is the level of detail we get of the valves. Notice the thickening of the valve leaflet here. So this is HALT, hypoattenuated leaflet thickening. And when we zoom in, you can see how well this is depicted. We even see that the valve leaflet, the tip here is not thickened. Also notice the level of detail of the aortic wall. I mean, often we don't even see the aortic wall on a CTA, but here we can really visualize it in high detail. We can also, this was done with retrospective EKG-gated acquisition, so we can do cine imaging, so we can nicely visualize the leaflet movement. This is the leaflet with the HALT, which is moving normally. There's no severe obstruction or anything, but this is imaged at really, really high detail. And then, of course, the coronary arteries, again, showing the high level of detail from the plaques, the calcification here, even showing that it's not only calcification, but there is some non-calcified plaque on top of it. And when we take out one of these TAVI valves, and when you scan them ex vivo, what I really like is the level of detail you can get, because in these valve stents there is this marker, this C, and you can never see the C on CT, but when you scan one of these valves with the photon counting CT with 0.2, we can even see the C here in the valve stand, and I think that is truly amazing. So in conclusion, I think dual source ultra high resolution photon counting CT is here today. Especially the increased spatial resolution is going to help us with visualizing coronary as well as cardiac anatomy. We can use higher kernels routinely to increase the spatial resolution and the sharpness of the imaging. We can reduce calcium blooming artifacts, making more patients eligible for coronary CTA, improving plaque assessment and visualization, as well as improving prosthetic heart valve imaging. And with that, I'd like to thank you for your attention.
Thank you very much, Ricardo. Wonderful as well. I just wanted to end with 2 or 3 slides before we open it up to questions, because it's an important consideration. This is a completely new level of detector technology. We can't treat it like it's a conventional energy integrating system. The thing that we talk about first with our customers who are joining us on this journey and installing this, you can't treat it like it's a force. You have to move past it, because you get drastic levels of quality different. You can't just copy your protocols from one system and move it over. It's a consideration of the better spatial resolution. You can just do more without the level of noise. Those images that both Lynn and Ricardo showed clearly demonstrate. And so it is a process. It's not an immediate plug and play, but it's the concepts of dual source that many of you already know. You use them, but let's push the boundaries to see the level of detail and plaque that we can get. And so in order to drive this further, obviously we have standard education practices in the United States. You get your applications, but we've even developed a new role here in North America, specifically focused on helping you, because it's a partnership. We want to invest in you. So every customer that is getting one of these scanners, our expert comes, visits, works with your physicians in addition to all the applications. That's typically for technologists. You don't get as much time. It's the ability to push the boundaries, because we want to focus on best practices. We know now what all of our institutions are doing around the world. How can we do this to push the field further? Do multi-center trials, multi-center studies. If we're doing different things in different sites, it's complicated. So we want to push the boundaries and drive it forward. And I open it to you as the experts in the field. Now that you can see the level of detail, the speed, the spatial resolution, spectral information, what are the questions that we need to answer? What are the new horizons that we'll be able to use? And this is what we need to explore together over the next number of years. So, really great. Would certainly be happy to open the floor up for questions.